So it is the day 3. Theme of the day is choosing antibiotics intelligently. So what we learned on day 2, it is infection versus colonization and specimen selection. What specimen will you select, where you expect that more pathogen will be there, and blood cultures, diagnostic thinking. So, why do two patients with the same organism they receive different antibiotics? The answer lies in host factors, site of infection, severity, pharmacokinetics, pharmacodynamics, resistance mechanism. So, for pre-round, patient 1 is 65-year-old diabetic male. So, he is diabetic, and in blood culture E. coli was there. So susceptibility report says that ceftriaxone is sensitive, piperacillin tazobactam is sensitive, and meropenem is sensitive. And diagnosis is urosepsis. So current treatment going on is meropenem. So the question is, why is he receiving meropenem? Is it necessary or its habit to give these type of drugs, or any fear that he is having urosepsis, or it is evidence based? So the principle says that just because meropenem work doesn't mean it should be used. Ask, what is the narrowest effective drug? This is antimicrobial stewardship. So out of these 3 sensitive drugs, we should see which one is of the narrowest spectrum and can be effective. So antibiotic thinking framework, it should be that before prescribing any antibiotic drug, what all you should think: what organism am I targeting, where is the infection, means what is the site of infection, whether this drug will reach there or not, does the drug reach that site, is source control needed, that from where this infection is coming, that you have to control, can I de-escalate later? So pharmacodynamics, this separates an ID physician from a general person. So, or time dependent killing. So example is penicillin, cephalosporin and carbapenems. The goal is that T should be more than MIC, meaning maintain the drug concentration above MIC for as long as possible. So this is known as time dependent drugs. So where you have to see that MIC should remain more than this concentration for as much as time you can be kept. So clinical implication is extended infusion may improve efficacy. Concentration dependent killing. What is concentration dependent killing? It is shown by aminoglycosides and fluoroquinolones where Cmax is more than MIC. So meaning is high peak concentration is important, means concentration of drug should remain as high as possible. So exposure dependent killing, example is vancomycin, goal is AUC per MIC. So this is known as augmentation or exposure dependent killing. So patient improving on meropenem, can we reduce frequency because he looks better? Answer is no. Antibiotic dosing follows PKPD principles, not emotions. So site specific antibiotic selection, case is meningitis. In blood culture they get streptococcus pneumoniae. Question is that can every sensitive antibiotic be used? No, drug must penetrate CSF in case of meningitis. So you have to see that out of those sensitive drug, which drug can penetrate the CSF. Now, in case B, prostatitis, many antibiotics fail because of poor prostatic penetration. So, that you have to see. In case of endocarditis, vegetation contains bacteria, fibrin, platelets. So, they require prolonged therapy and the bactericidal drugs. So here the teaching pearl is that always ask, can the antibiotic reach the site? Not, is it sensitive? Then lunch, in lunch what discussion you should do, that patient is having persistent fever despite antibiotics, CT abdomen is showing 5 centimeter liver abscess, culture sensitive organism is found. So, should we add another antibiotics? No. What is missing? Source control. Means abscesses is still there. So, lifelong rule is antibiotics do not drain pus. So, you have to drain the pus in this case. Resistance mechanism every ID fellow must know, like ESBL. So the common organism showing this is E. coli and Klebsiella pneumoniae, and effect is they are resistant to many cephalosporins, so you cannot give cephalosporins in this case. MC common in Enterobacter cloacae and Citrobacter frondi, so can emerge during the therapy. So this resistance can emerge in these organisms during therapy. So carbapenemase example is NDM, KPC and OXA48. They are also the major concern in modern hospitals, so we should look for them whether they are present or not. So stewardship round, patient is afebrile, stable, blood culture is negative, CRP is falling, that means infection is going down, but the patient is still on meropenem, teicoplanin, colistin. What drug was being given, it is still going on. So what's wrong here? Antibiotic accumulation without indication, and it should be tapered down. So stewardship checklist says, is infection proven? Can therapy be narrowed? Can one drug be stopped? IV to oral switch, correct duration. So end of the day, at the ID grand round, the rapid fire question is most important step before starting antibiotics. Appropriate cultures, most important reason for antibiotic failure, inadequate source control, most important stewardship intervention, de-escalation when appropriate, most important factor in antibiotic choice, clinical syndrome and site of infection. What assignment is given, that for every antibiotic prescribed, one should write why was it started, what organism is targeted, does it reach the infection site, is that organism is resistant to it or not, is source control adequate, can it be narrowed, or planned duration for how long you are going to give. So these all questions should be checked while prescribing any drug or antibiotic. So if a microbiologist may ask what organism is this, an infectious disease physician may ask why is this organism here, does it explain the illness, and what is the safest effective treatment, means is it pathogen or it is commensal or colonizer. So what is the safest effective treatment if it is pathogen, that mindset is always what you have to develop. And we in the case of in day 4 we should see approach to fever and fever of unknown origin, one of the most intellectually rewarding areas of the infectious diseases, fever and fever of unknown origin, and the antimicrobial stewardship is also the part of it. So these things should be checked, and this is from just chat gpt. If you find any something wrong, then you can write it down in the comment box.